20-year-old Jessica Ross and her boyfriend, Travion Taylor Sr., have an unimaginable story. Their attorney says the young couple was full of joy and anticipation for their first child. They came here to Southern Regional Medical Center for the delivery July 9th. According to the complaint, doctors had diagnosed Ms. Ross with diabetes a year earlier, making her a high-risk pregnancy. But she consistently went to appointments while she was expecting. The couple's attorney says after about 10 hours of labor, Jessica was fully dilated and ready for delivery of Travion Jr. But according to the complaint, they say his shoulders got stuck in the vaginal canal.
What wound up happening after that is just brutal. Dr. St. Julian came in and she, in the process of trying to deliver this baby, pulled on the baby's head and neck so hard and manipulated them so hard that the bones in the baby's skull, face, and neck were broken.
So I'm going to start today's episode by being a little bit practical. So you have been monitoring this woman in labor as a parturition, and she's currently in the second stage of labor. That's the stage of full dilatation to the delivery of the baby. But you haven't delivered the woman yet. You haven't delivered the baby yet. She's just commencing the second stage. She's fully dilated. And the fetal head is crowning, which it should normally. And external rotation has taken place. But what you notice is there is some retraction of the baby's head towards the introitus of the woman or the vagina of the woman. You notice the baby's head going back, like something is pulling it back to the vagina of the woman. So what do you think is going on? What do you have in mind? What is the diagnosis? So in today's video, guys, I'll be talking about shoulder dystocia. I'll be talking about those factors that can put a pregnant woman at the risk of having shoulder dystocia. I'll be talking about the complications of shoulder dystocia, and I'll also be talking about the management and treatment of shoulder dystocia. So with each obstetric emergency, of course, shoulder dystocia is an obstetric emergency. With every obstetric emergency, it's always good to know the definition and meaning of that obstetric emergency. So shoulder dystocia is simply the inability of the fetal shoulders to deliver spontaneously. This is because they are stuck or impacted behind the maternal symphysis pubis. That is the meaning of shoulder dystocia. Inability of the fetal shoulders to deliver spontaneously because they are stuck or impacted. That's particularly the anterior shoulder is stuck or impacted behind the maternal symphysis pubis. So this is what shoulder dystocia is all about. So what are those factors that can put a pregnant woman at the risk of having shoulder dystocia? The first factor that can put a woman at risk of having shoulder dystocia is maternal obesity. Yeah. What I've realized in most institutions that I've been an intern or a worker in is that during antenatal clinics, they don't really screen for gestational diabetes, which it should be a good practice. Screening for gestational diabetes, that's screening every pregnant woman for gestational diabetes, should be a good practice, because gestational diabetes during pregnancy can predispose a woman to having shoulder dystocia during the second stage of labor. Because with gestational diabetes, there is some buildup of fat due to excess glucose and all that. There's some buildup of fat on the shoulders of the baby. So this can eventually lead to shoulder dystocia during the second stage of labor. So screening for gestational diabetes during antenatal clinics is important. Yeah, because maternal obesity, gestational diabetes are predisposing or risk factors that can put a woman at risk of having shoulder dystocia. And another factor is fetal macrosomia. That's big babies. Obviously, most women who have been diagnosed with gestational diabetes often have very big babies. And now let's talk about those complications of shoulder dystocia. I'll be talking about the complications for both the mother and the baby. So firstly, for the mother, what can happen is that during shoulder dystocia may cause the mother to have severe vagina and perineal tears. And there's another complication, which is the postpartum hemorrhage, which is life-threatening for the mother. So these are the most common complications of shoulder dystocia for the mother. And the most common complication of shoulder dystocia for the baby is brachial plexus injuries, like Erb's palsy. That occurs when a certain nerve is being damaged, and it results in total paralysis of the baby's arm. So these are the complications of shoulder dystocia for both the mother and the baby. And now let's move to the treatment. How can you manage shoulder dystocia during that second stage of labor? But before we go to the treatment or management, let's first talk about how we diagnose shoulder dystocia. So the most effective and common sign of shoulder dystocia is the turtle sign. I've explained it before, but I didn't mention this name. It's called the turtle sign. The turtle sign is when, after crowning and external rotation of that baby's head, you notice a retraction of that baby's head, like something is pulling the baby's head back to the introitus or the vagina of that woman. That is called the turtle sign. That's the most effective sign and most significant sign that will tell you that this is shoulder dystocia going on. And shoulder dystocia is an obstetric emergency. If effective management is not being done, that baby is going to end up asphyxiated, as there is going to be insufficient supply of oxygen to that baby, and may eventually lead to a stillbirth. And we don't want that in obstetrics. Maternity is the most important unit in any health institution. We are dealing with two lives. It's not just the mother. We are dealing with the mother and the baby. So we don't want to mess up. So we need to take prompt and effective management in every obstetric emergency. So the first thing you want to do is, after you notice that turtle sign, the first management for every obstetric emergency is that you need to shout for help. Before you start doing anything else, you need to shout for help, because you are going to need extra hands to be able to remedy that situation. Shout for help. Shout for help. Okay. So after shouting for help, what you're going to do is, in the case of shoulder dystocia, after shouting for help, what you're going to do is you're going to perform what we call the McRoberts maneuver. The McRoberts maneuver entails that you place that woman in hyperflexion, because normally a woman should deliver in the lithotomy position, right? Yes, a lithotomy position. But when shoulder dystocia is being diagnosed, you need to place that woman in hyperflexion. That means both her legs need to be hyperflexed up to her abdomen. Yes, hyperflexed to her abdomen. Because what you're trying to do is that you're trying to create more room. You're trying to push her sacrum behind so it can be aligned with her lumbar spine in order to create more room. Broaden her pelvis as much as possible for that baby to pass. Because those shoulders are stuck and they need more room. They are stuck. So you want to broaden that pelvis. You want to try and move those shoulders which are stuck behind the maternal symphysis pubis. So after hyperflexing her legs, that's after performing the McRoberts maneuver, the next thing you want to do is you want to perform a suprapubic pressure. That's a suprapubic pressure, is applying pressure just above her symphysis pubis. That's just applying pressure, not fundal pressure. Fundal pressure is being done at the fundus. That's the highest part of the uterus. You're applying pressure here at the fundus. But suprapubic pressure is being done just above her symphysis pubis. That's you're applying a downward pressure at that area. Because you're doing that in order to ensure that the anterior shoulder, which is tucked, lifts the back of the symphysis pubis down. That it lifts away from the symphysis pubis because it's stuck behind that symphysis pubis. But when you apply suprapubic pressure, it's going to displace that shoulder from the symphysis pubis to another area, which is going to ease the baby to come out. Fundal pressure is counter-indicated, it's contraindicated. We don't need to apply fundal pressure when there's shoulder dystocia, because this might predispose the baby to more risks. This might predispose the baby to having more brachial plexus injuries. So fundal pressure should not be applied during shoulder dystocia. And I also advise that with apart from performing the McRoberts maneuver and performing the suprapubic pressure, it's also advisable to give an episiotomy. You're trying to create more room as much as possible, so give an episiotomy. Yeah, it's important, it's going to help. So guys, this is the most effective management of shoulder dystocia. It's both theoretical and practical. When you apply these mechanisms, it's really going to help save the life of the baby and that woman.